So our next topic we're going to go through is our vent, and not only specific to our vent, but just ventilator basic knowledge. So if you're taking a patient with RT or even just with bagging, some adjustments you can make to improve patients' either respiratory or cardiac status. So we're going to understand basic principles of vent management, know how to troubleshoot basic ventilator complications. I'm not asking you guys to become respiratory therapists and know every maneuver to do and get understanding of in-depth vent management, but just basic troubleshooting. And then go over our transfer protocol that we kind of reviewed previously for our vent-dependent patients. This is our ventilator. There's another sitting up front there. So this is the one we have currently. From our understanding, is this can only be used by the CCPs. It's not considered for just PS or paramedic level. Basic settings on our vent or any vents in the hospital or ones you might be picking up somewhere else are your mode. We'll go through all the kind of basic different modes. Tidal volume, your inspiratory flow rate, your respiratory rate, and then your FiO2 and PEEP. So modes. All sorts of different modes. Assist control is the one we're going to focus on, but just so you guys understand what all the other ones are, in case you're taking a patient out of the ICU or going to Marshtown, picking one up and bringing it here, you understand if they're on one of those others, what those mean. So assist control, volume control, assist control, pressure control. There's pressure support. There's SIMV, or synchronized intermittent mandatory ventilation, and both those have volume and pressure control. So assist control means they have a set tidal volume if it's on volume control, or they have a set pressure and time if set to pressure control. It's delivered at a minimum rate, and if the patient's breathing above that, they will be assisted in all those breaths. So that means you might set your rate at 10 and a set either tidal or tidal volume or pressure control, and if they're breathing at 14, they get assistance with all 14 breaths. Every breath will be assisted by the ventilator. So if they're not breathing at all and you set it at 10, they're going to get 10 breaths. If they're breathing at 20, they're going to get 20 assisted breaths. So kind of think of it that way in the simplistic view of it. With pressure support, the patient controls the respiratory rate, and they do the major influence on the duration of inspiration. So how long they're inhaling, how long they're exhaling, and tidal volume. So this provides support to overcome increased work of breathing that is caused by having the endotracheal tube in place, all that dead airspace that we talked about, all the inspiratory valves and the mechanical aspects of the vent. SIMV, you'll see a lot of patients upstairs who have been on the vent for a few days. They'll set them to SIMV. They're given it a set minimal rate. If the patient is breathing above it, they do not get support on those breaths. This is kind of what you may switch them to, is where if they're on the vent for a long time, or if the goal is to wean them off the vent and allow them to start taking over some of their own respiratory drive without assistance on every breath. It requires a greater work of breathing, so not a great setting to jump to right after you've intubated somebody. And it can deliver set tidal volumes or set pressure. So it has a pressure choice or a volume choice. These, because the negative inspiratory pressure generated by the spontaneous breathing and not assisted, leads to increased venous return. Theoretically, they may do better from a cardiac standpoint long term if they're switched to this after their initial placement. But the big thing to think about is if they're on this and they're breathing at 14 and you've set your rate at 10, you are only getting 4 independent breaths. All other 10 will be assisted. So anything above your set rate is unassisted ventilation. Where assist control, they're breathing at 14, they're getting complete assistance with all breaths. So kind of advantages of each mode. Assist control, with, you're going to get guaranteed set tidal volume and reduced work of breathing compared to breathing on their own. With pressure, it allows limitations of the peak inspiratory pressure, so you can regulate how much pressure is on those airways. With pressure support, patients tolerate this better, much more comfortable, and they kind of interact with the ventilator. So you time it. So again, not what you put them on initially when they're paralyzed and sedated, but moving towards. Or SIMV, might see this on a post-CABG patient who's waking up and doesn't stress the cardiac function as much, allows them to do some of their own breathing, but they may need the vet a day longer than they should have just in the OR. So those are the kind of patients you'll see on SIMV. Disadvantages with assist control, whether it's volume or pressure control, is your effect on your cardiovascular function. So they can get hypotension and hyper or hypoventilation with the assist control setting. With pressure control, the apnea alarm is only a backup and variable the patient tolerates. Some can't relax enough to coordinate with the vent. And SIMV, it's increased work of breathing. So in a fatigued, bad diaphragmatic fatigue patient, this is not what you want to put them on because they're still using so much of their muscles to do the work. Okay, so that's kind of the complicated overview of all the settings. Now we're going to try and make it a little more simplified for our level. So there was a great lecture I showed a couple years ago. It's no longer online, but and it was ER doc who simplified it in for pre-hospital and ER into two categories. You either have your lung injured patient, so that is your bad pneumonia, your CHF, they've got a trauma, so they've got a pulmonary contusion, they've got a pneumothorax, hemothorax, they're an ARDS, or you intubated them for non-respiratory reasons, so to protect their airway because they're a neuro patient and bad head trauma. Then your goal is to prevent lung injury. So most of your patients, if they're not COPD or asthma, they are going to be in that lung injury category. So pretty simple. COPD, asthma are in your obstructive category. Those are the only two. Everything else is either an injured lung or preventing an injured lung. Makes it much easier to think through your process and how you want to set your vents up. So for both of these, we're going to focus on 3 or 4 basic buttons that you can mess with. And if you know those 4 buttons, you can easily change your settings and make your patient more comfortable or improve their ventilation and oxygenation. Tidal volume, your inspiratory flow rate, your respiratory rate, and your FiO2 PEEP, and we're going to kind of put those into one category. So you place all your patients on assist control because we talked about it's the easiest thing for them to tolerate. You're helping assist them with every breath. Doesn't matter how much they're breathing on their own, they get help. And in your handout, I also gave you kind of this it's not the PowerPoint, but the ventilation strategies. This is taken from the previous lecture that was based on this, and that's ARDSNet. And that is a really large study group of lots of data coming in that showed that if you do this management in these acute patients, they have improved survival. Less lung damage and improved survivability in assist control versus all the others in the acute phase. So with assist control, you put in a tidal volume and a respiratory rate that the patient gets no matter what. So every time they take a breath, they're going to get a set tidal volume, and they're going to be guaranteed a minimum respiratory rate. So in a protected patient, so the lung injured type patients, that's all your patients except for COPD and asthma. Your tidal volume is somewhere between 6 and 8 cc's per kilogram of ideal body weight. So there, I can show you guys a calculator of ideal body weight based on height and weight. So you look at the patient and say, they shouldn't weigh 350 pounds. This is really a 200-pound person. You can't go up to 350 because they still just got those little lungs sitting in this giant body. Their lungs don't get bigger because they get fat or because they're Michelin men with retained fluid and third spacing. Lung size doesn't change, so you have to go on ideal body weight, not on their actual weight. And if this ARDSNet studies have shown that if you increase their tidal volumes too much, you increase their lung injury. So if you think about it, all these lung-injured patients have, quote, baby lungs. They tolerate less volume. They don't tolerate it. And if you think about it, here's a picture of some pulmonary contusion and some fluid. So what should be all of this lung space now has fluid in there and consolidation. None of these parts of the lungs can get ventilated. There's no gas exchange going on there. So you have much less lung to ventilate and oxygenate. So you have to treat them delicately like they're little lungs. Your inspiratory flow rate is your second setting you'll adjust, and that is all about comfort. If you think about it, when you sit here and breathe, if you're made to take a slow inhale breath, it's not very comfortable to do repeatedly. We inhale fairly quickly, and a slow breath makes them kind of air hunger, and it'll make them anxious and restless. So a higher flow rate is much better tolerated. It's even higher in your COPD asthmatics, but in here, 60, 80 liter per minute is best tolerated for comfort. And if they seem to be bothered by it, you can up that to even faster, because that's how quickly you expand their lungs. You don't want them slowly breathing in. And your respiratory rate is all about your ventilation. So you and I sitting here use 60 milliliters per kilogram per minute. If we're resting, not talking, not moving, sitting, that gets us eucapnia. When you put them on a vent, and you look at that vent sitting up there, all that tubing, that endotracheal tube, all that's dead space. So they essentially need twice the volume when you're on a ventilator. So all that space doesn't get a gas exchange in it. So then they go up to 120 mLs per kilo per minute. So for a 70-kilo man or woman, at 120, that's 8,400 milliliters per minute to maintain. So it's a 500 ml tidal volume, because you're back to your 6 to 8 milliliters per kilo tidal volume. So you take 8,400, how much you need in a minute, divided by your tidal volume is 17 breaths per minute. So an easy way to calculate your respiratory rate. Questions about that? And then your FiO2 and PEEP. So right after you intubate somebody, you put them up to 100% for the first few minutes. Get them well oxygenated. You wait 5 minutes. If you're in the ED or the ICU, we're going to get an ABG. If you're in the field, obviously you can't run an ABG. You have your pulse oximetry and your end tidal. So you drop it down to 40%, and you look at your sats. Like we talked about earlier, I don't want to see PaO2s of 100%, because that means your PaO2 could be 400 or 500. That's not good on all of our tissues to be running that high of oxygen levels in your blood. So you want to drop them down to 40, and obviously if they desaturate and their pulse ox is down to 70%, as soon as you do that, you got to get them back up, and they may have to stay on 100%. But you only go up if your oxygen saturation is dropping below 95%. Otherwise, they're set at 95, leave them at 40. They're set at 99 on 40%, drop them down to 30. Question is, should they have been intubated if they're able to maintain a sat of 98% on 30% FiO2? And some vents, you'll run those, they'll be kind of dual. Ours is separate. Your FiO2 and your PEEP are two separate dials or buttons. And there is, on your handout, the scale for, if you look at your injured patients, of your FiO2 and PEEP that we'll get to in a minute. But kind of find that, and that kind of teaches you how to go up on your PEEP and your FiO2. So in injured patients, these patients can tolerate PEEP. Talk about COPD and asthma patients, you don't want to add PEEP on those. These guys, you want PEEP. It helps keep those airways open because they've got fluid, they've got trauma to them, so they need a little support to keep that airway open from collapsing. So if you look at this slide, it talks about recruited alveoli. Nothing down here, so there's nothing to help keeping it open. This keeps it somewhat open, and you get airway improvement, opens it further. You don't want big expanded alveoli with so much pressure, because then they're not exchanging gas as well either, and you're causing barotrauma. So you got to keep them in that kind of optimal with the little peep, keeping those alveoli always open just a little bit. You don't want them smashed down so it takes so much pressure to overcome and open them, but you don't want them sitting there almost fully extended before any ventilation goes in. So this is that scale on your handout that talks about going up on your FiO2 and up on your PEEP. So they kind of go up in conjunction. You don't want to just ramp up to 100% FiO2 with no additional PEEP in an injured patient. They need that, they're clearly needing that PEEP to keep those airways open to have gas exchange. So you start, at 5 PEEP at 30 to 40% FiO2, up your PEEP to 8, then you're gradually upping your FiO2 until you're maxing out at 100% and a PEEP of 18 to 20, somewhere in there. So they may require a lot of PEEP in these bad injured ARDS patients. They've got complete third spacing and lungs completely full of fluid. They've got so much pressure pushed on the outside of those, you need so much pressure to open those alveoli to get them to ventilate. Because it doesn't matter how much oxygen you're given, if you can't open those alveoli, they can't exchange their gases. So why do we use PEEP? It improves your VQ mismatch, that whole ventilation perfusion, decreases the shunting, which is going to decrease your pulse oximetry if they're shunting, decreases atelectasis, because that's when your alveoli kind of stick together. That's why you see patients come out of the OR and they have a lot of the bottom of their lungs look like they've got a pneumonia because they weren't fully expanded in the OR. And so now they have all these portions of their lungs and all the alveoli that kind of stick together and smashed. And we need to help open those in trauma patients and make sure they're using the base of those lungs. Why is it bad? It decreases your venous return, so it can cause some hypotension, which means they may need more fluid. And if they're already third spacing, you're fighting that kind of circle that you get more fluid, now they third space more, they don't have the protein stores, and you get more ARDS. Ugly myth is it does not cause pneumothorax when used appropriately. I mean, if you put them up a PEEP of 20 on a COPD patient, yes, you might cause a pneumothorax. But when used appropriately, it does not cause pneumothorax. Pressures. So peak pressures, that's what's going to make that thing scream at you nonstop, is a peak pressure. It makes this machine alarm, it doesn't really mean much of anything when you really look at the literature. It's really getting a plateau pressure. That's what you want to keep below 30. You don't need your peak pressures to be below 30, but you need your plateau pressures to be below 30. If they're greater than 30, that's when you get your risk of barotrauma and pneumos and large. So it's not so much the PEEP as it is just the total pressure. So you decrease your tidal volume. If you're expanding out and putting so much into those lungs that they're getting pressures above 30, you need to decrease that tidal volume so there's less going in so you're not expanding. You may have overestimated their ideal body weight as the most likely scenario to have that increase. You do it by an inspiratory hold, and we'll walk through. Pepper, do you know how to do an inspiratory hold on that? So that's the real way you get plateau pressure. Is there's a setting on there and the inspiratory hold, so they take in a deep breath and they hold that on the vent. That gives you your plateau pressure. So I don't care what this peak inspiratory pressure is up here. That really means nothing. This plateau pressure is what's really looking at the pressure on the alveoli themselves. Not this kind of peak up, but where are they at with an inspiratory hold? How much pressure are those alveoli getting exerted on them? Okay, before we move on to obstruction category, any questions, discussion on the injured, pathophysiology, and why you do what you do? Anybody who's used it that wants to comment? Pepper, have you taken patients that were like asthma COPD or chronic vented for other ARDS? And so more of the injury pattern patients. Okay, so I mean, we have the potential. We probably won't be transferring these. The only time I could see you guys probably have an asthma COPD is if you're tubing in the field and we get to the point where we have a transport vent that's easily set up. So probably less of these kind of patients that you'll be doing long distance transports on, because we keep these kind of patients here. So these patients, they have a ventilation problem, not an oxygenation problem. And you have to give asthma and COPD patients as much time to exhale as you can. Their problem is exhaling. It's not inhaling. It's exhaling and getting rid of that. That's why, think about it, that's why COPD and asthma patients have long lungs and kind of barrel chests, because they can't exhale and they're keeping all that in there. And that's what a kind of classic X-ray look. You see how their diaphragms are all flat down here instead of arched up, nice, big, tall lungs, because they're hyper-expanded. They're not exhaling. Again, set these guys in assist control. They're the same setup as the injured for their setting, their mode. Their tidal volume on these aren't baby lungs. These are big lungs without injury to them, so they can take more volume. So they're up at the upper limits, the 8 mLs per kilogram of body weight. So that's really one of the big changes between obstructive and injured, is you go more volume, and we'll talk about the flow rates here in a minute. And your inspiratory flow rate, you want to set these a little higher. These patients inhale pretty fast. If you remember looking at asthmatic, they're inhaling fast. And those bad COPDers are sucking in, and then they can't get it out, and that's when they have their expiratory wheezes. So they're a little bit faster, the 80 to 100 liters per minute, and it keeps them much more comfortable in tolerating the vent much better. And again, if you're FiO2 PEEP, you start them at 100%, drop them down to 40%, follow your scale of your FiO2, and you keep between 88 and 95%. PEEP initially in these, you guys start at 0 or ZEEP. They shouldn't have PEEP. And we'll demonstrate in a lung here kind of what that looks like. But if they're already hyper-expanded, they're open. You don't have the issue of their alveoli collapsing in. They're already open from all their pressure. They don't need it added, because they start breath stacking, and they'll auto-PEEP potentially themselves. So PEEP is not something you want to add in initially. Kind of see how they tolerate the vents. Sometimes you have to add a little, but you do not want these patients up with high PEEPs. So respiratory rate is going to be your most important setting in obstructive patients. This is how you protect their lungs in obstructive patients. You protect it by their tidal volumes in the injured patient, protect it by their respiratory rate in a COPD asthma obstructive patient. So you start down low, 10. You're injured, you're going to be 16, 17, 15, 18, somewhere in there. These guys are 10. Remember, they can get air in, they can't get it out. So you're looking for your inspiratory to expiratory ratio to be longer. In a normal patient, it may be 1 to 2, 1 to 3 in an injured patient. COPD patient, you're looking at 1 to 4, 1 to 5. They need more time before that next breath comes to inhale so they don't auto-PEEP. And you allow for a PA CO2 to be higher in these patients. When they're already vented, if you're oxygenating fine, we don't care that they're a little more obtunded and have a higher CO2. They can ride a little higher in these patients. Not doing anything wrong with them. They can be a little more acidotic. You let them go so that you're ventilating them better. And this is kind of a pictorial of air trapping. So if you look at this, here's your inspiratory, expiratory, and then you start another breath here. They didn't get time to fully exhale, so now here's where their alveoli are sitting before their next breath. They don't get back to baseline. So if their breaths are sitting at 14, they haven't had time to exhale. You drop the breaths to 10, that just by the nature of slowing their breath down gives more exhalation time before their next breath comes. So you don't stack your breaths on these patients. That's kind of the theory of why you have a lower respiratory rate. So what happens in obstructive patients? They auto-PEEP. And that's back to this. This is basically like PEEP sitting there. So you do that multiple times, and they breathe at 20 times a minute, even if they're not on the vent and they're doing that. That's what they're doing to themselves. They're auto-PEEPing and stacking their breaths and not exhaling. So again, this is why we check plateau pressures, not peak. These patients' peak pressures are going to be crazy high. They might be 40, 50. If it's greater than 30, you don't need to change their tidal volume. You need to change their rate and give them more time to exhale, because that means if it's greater than 30, they're still auto-peeping, and you need to give them more time to exhale and more time. So sometimes you have to drop the respiratory rate down to 8 in order for them to get rid of some of that auto-peep they've had, and then you may have to go back up. These patients need sedated. Whether they're the lung injured or the obstructive patients, they need sedated. They need pain meds, like we talked about in your RSI and your capnography lectures and all those before. Pain meds first. Give them morphine, give them fentanyl, give them Dilaudid, give them whatever your drug of choice is, get them pain control. They will tolerate the vent better, they won't fight it, they'll work with your vent much better. Then, if you're maxed out on your pain meds and you're still getting trouble with them tolerating the vent, doing well on it, that's when you add in your benzos, your propofol, ketamine, and you have to look at your clinical picture. What's their blood pressure? Can they tolerate a propofol bolus? If their systolic's already 70, you probably can't give them a dose of propofol. Then look at ketamine, making sure they're not on it because they're a neuro patient and head injured, and you're not going to give them the ketamine dose. First said, not going to tolerate it again if they're hypotensive. Ativan, they'll tolerate a little bit better hypotension with Ativan. And like we talked about before, paralytic agent is your last resort, and pretty much only for our induced hypothermia because they're shivering and are not responding to pain meds and sedatives, which is actually a good sign. So again, do we redose sucks? No. Don't want to do a second dose of sucks. You'll give a dose of rock is what's in our transfer bag. And we have our protocols that we went over before for our sedation and interfacility transport. So I think putting this kind of summarized in our vent bag will be our next step. Get a laminated card that kind of has all your settings in it and your FiO2 PEEP. So if you are pulling it out, you have something to kind of recall rather than trying to get back to a handout on all your settings would be good. The PEEP. Yeah, I think just kind of putting this in a really simple obstructive and right. So for recording, that's all we need to do. I'm going to take this off, and I'm going to play with our vent here a little bit.